ultrasound, not available in village level or district level also for screening, delayed referral to tertiary oncology center. So for Tripura Regional Cancer Registry data highlights urgent need of community level screening program targeting high risk females aged 40 to 65. So risk factor for gallbladder cancer is mainly the gallstone, presence around 80 to 90% cases. Chronic mucosal irritation by gallstone drive malignant transformation, and high fat diet, obesity increases the gallstone formation. So our diet should be changed. Genetic and anatomical, that is anomalous in pancreaticobiliary junction, porcelain gallbladder, that is mainly the deposition of calcium where gallbladder wall becomes rigid, so there will be more inflammation, and familial, of course, familial clustering is there. Infection, Salmonella typhi, Helicobacter pylori, that causes chronic infection, leads to carcinogenesis. Environmental, petroleum, heavy metals like arsenic, cadmium, aflatoxin, industrial chemicals raise increased risks of gallbladder cancer. So coming to clinical features, gallbladder cancer is very much silent in early stages because patient doesn't report, they report as gastritis only. So frequently primary level physician used to give gastritis medicine, they never do a sonography. So it should be mandatory, like every patient who is coming with dyspepsia, appetite loss, pain in right hypochondrium, right side hypochondrium, they should be screened at least once for gallbladder disease. Early symptom and early stages, there may not be any typical symptoms. So non-specific, easily attributed to benign gallstone disease, and there will be delaying diagnosis by months to years. And properly when it size increases, patient is to have right upper quadrant pain, dull colicky discomfort indistinguishable from biliary colic. Dyspepsia will be there, nausea, vomiting may be there, postprandial bloating, fullness of abdomen, indigestion, and early satiety. Incidental discovery like around 20% cases. Post-cholecystectomy gallbladder disease presumed to be benign disease, but it usually comes as gallbladder cancer later on. In advanced diseases, anorexia, weight loss, all are classical bliss symptoms, and palpable mass. When its size increases, tumor size increases, we can palpate a non-tender right upper quadrant mass in late stage of the disease. And the clinical signs, physical finding, there may be hepatomegaly, tender liver enlargement due to direct invasion to the liver. Corvosius site, palpable non-tender gallbladder in a case of jaundice. This may suggest as a malignant transformation. Ascites may be there in late stage of the disease, that present as a shifting dullness. The typical advanced presentation will be like this only, yellowish colored body of patient coming in our OPD with cachextic look, loss of appetite, yellowish urine for last 3 to 4 months. So the main important thing is recognition of even subtle early signs by primary care physician remains the most important step towards the providing outcomes in endemic region like Tripura and Indo-Gangetic belt. So diagnosis, routine investigation, imaging, tumor marker, histopathology, and staging workup. Diagnostic challenges nowadays, it will be non-specific symptoms because patient may tell like simple gastritis only for last 6 to 12 months, and physician also do not care for any other diagnosis. They usually prescribe PPI only. Incidental finding, cholecystectomy. After cholecystectomy, there may be gallbladder cancer. But patient usually do not refer, patient party usually do not come to cancer center because of stigma or some other economical condition. They may think like it will cost more money for cancer surgery. But we are doing all the oncological surgery free of cost in regional cancer center. Limited screening, no validated population level screening program exists for gallbladder cancer even in high risk region. So imaging modality, the easy imaging modality, first line is ultrasonography, detects gallstone, focal wall thickening, polypoidal mass, bile duct dilatation, that is easily available ultrasound, so it should be done for all the cases. Second is CCT, whole abdomen contrast enhanced CT scan evaluates local invasion, lymph nodes, vascular encasement, and distendments. Next comes MRCP, to see the biliary tract, superficial soft tissue contrast, delineates the bile duct, involvement of tumor extent essential for surgical planning. And at last, PET scan, which is not available in all the centers. Our center is having PET scan. That if we do PET scan in early stages, we may rule out even in early stage disease also may have metastatic chances. So in CT scan, less than 5 mm lesion we cannot find. In PET scan, we can find the functional outcome. Even early stage patients or small lesion in other part of the body. So PET scan nowadays it is routinely done in maximum cancer center, tertiary cancer center. Laboratory and tumor markers, the most important thing, all the routine investigation we used to do like complete hemogram, kidney function test, liver function test. Above that we used to do mainly liver function test, we used to see the bilirubin level, because bilirubin level if it is more than 3 we cannot go for any active oncological treatment. It should be less than 3. Then transaminases, GGT, LP we have to do. This CES here 99 is to tumor marker. We usually routinely do for all GIT cases. CA99 is more of prognostic marker for gallbladder cancer. It used to be elevated in almost 70 to 80% cases of gallbladder cancer, having sensitivity of 80% and specificity of around 60 to 70%. CEA usually it doesn't increase in gallbladder cancer, but gallbladder cancer associated with some other metastatic site. In those cases, CEA level may be increased. So both of these two markers we usually prescribe for all those patients who is coming for gallbladder treatment, and for follow-up also we used to do both these two tested just to see the response level and the recurrence rate for recurrence assessment. Because we cannot do always imaging for every 3 months. So these two tests we can do every 3 monthly to see the any recurrence is there. Physical types, more than 80% cases it is adenocarcinoma and mainly papillary type best prognosis. Squamous cell carcinoma around 5% cases. Adenosquamous, this is the worst prognosis. Because the squamous cell and adenocarcinoma, normally adenocarcinoma responds properly with chemotherapy, not squamous cell carcinoma. So mixed type is very aggressive. And neuroendocrine type, this is treatment part is totally different than adenocarcinoma. So TNM staging, I will not go in detail. So gallbladder cancer, the staging, T staging, mainly the tumor staging. TIS is early disease, that is carcinoma in situ. T1 disease, it is involved only in lamina propria or muscle layer. And T2 disease, it involves the connective tissue. This T1 and T2 is early stage disease. And involvement of lymph node or T3, T4 disease, it is already locally advanced. And metastatic disease, metastasis to non-regional lymph node. Regional lymph nodes are mainly the lymph nodes around the cystic duct, hepatic artery, portal vein, pancreaticoduodenal ligament, peripancreatic lymph node. Any lymph node outside that will be metastatic disease only. Like aortocaval lymph node is metastasis already. So any metastatic disease of gallbladder cancer, there is very less chance of cure. Group stage, what we have to remember, like I have given color coding like stage 0, 1, 2. These are almost 80 to 90% cases curable case. Stage 3 and 3B, we need adjuvant therapy like chemotherapy or any other adjuvant immunotherapy. Stage 4, already patient in metastasis, there will not be any cure. So we can give palliative chemotherapy or palliative radiotherapy or palliative care only. Some patient doesn't want any treatment, any oncological treatment. In those cases, we can refer them to homeopathy, we can refer them to Ayurvedic. Because we know the survival rate is only 2 to 4 months or 2 to 6 months. If chemotherapy response, it may go up to 1 year or 1.5 years, not more than that. So in those cases, we may refer those cases according to their plan. Patient party, even patient also doesn't want oncological treatment. In those cases, we can give them a capability of treatment option, homeopathy or Ayurvedic, whatever. So management part, mainly surgical, adjuvant chemotherapy and systemic chemotherapy or immunotherapy. So Treatment principle is surgery only curative option in gallbladder cancer if there is complete resection, and this is feasible for all those cases coming to OPD only in 10 to 30% cases, because around 60 to 70% cases comes in chemotherapy, maybe radiation therapy. In high risk cases, radiation has very little role in gallbladder cancer. If margin is positive after surgery, then only we can give radiation. Radiation in curative intent. Palliative intent, we can give systemic chemotherapy, biliary compression like stenting for unresectable and metastatic disease, just to prolong quality of life, just to prolong survival. So surgical management, surgery in detail I will not tell, just simple cholecystectomy. Patient comes in T1 disease, like if only lamina propria is involved. Extended cholecystectomy should be done in cases if it involves the muscle layer or beyond, with lymph node dissection. If it involves the liver, only one lobe or just direct infiltration to the liver, then there will be liver dissection. That also segment 5 and segment 4B with lymph node dissection. And extended hepatectomy, which rarely done in those cases because patient ECOG performance status, that is patient general condition, used to be so poor that we cannot go extended hepatectomy in maximum cases. So adjuvant therapy strategies for gallbladder cancer, we need adjuvant therapy after surgery if there is margin positive, if there is lymphovascular invasion positive, if node is positive, or any T2B disease or above T2B like T3, T4 disease. In all those cases, we need adjuvant therapy. Up to T1, like if only muscle layer is involved, no lymph node is involved, post-op T1, T2 and 0 disease, we may avoid adjuvant therapy. So adjuvant therapy, no involvement. If his general condition improves, then only we provide treatment. So decision will be done by our tumor board only. So adjuvant option, we have capecitabine tablet, that is oral chemo, disease, where there is spread towards the liver or lymph node is involved. In those cases, first we have to give chemotherapy around, if we are planning for 6-cycle chemotherapy, we will give 3-cycle chemotherapy before surgery, so that the tumor size shrinks, lymph node size shrinks, so that we can do an R0 resection. Rest of the 3-cycle we will give after operation. So therapy. We have to manage all those palliative cases, pain management according to the WHO ladder pattern for pain. We can do celiac plexus block, then we can give palliative chemotherapy just to increase the survival of the patient. Then biliary decompression, usually patient comes with obstructive jaundice. So first thing we have to do, we have to decrease the jaundice. So patient may go for ERCP stenting or PTBD, that is percutaneous biliary drainage. Then of course nutritional support in advanced stage disease, that is diet, management of cachexia to give the appetite stimulant. Nowadays we are giving methystrol acetate tablet just to increase the appetite of those gallbladder cancer patients. So Indian and Tripura data, regional challenges, resource landscape is late presentation of the patient. Maximum like more than 70% patient comes with stage 3, stage 4 disease. So curative resection not possible in maximum cases. PET scan, MRCP, molecular profiling remain limited outside the city area. And screening gap, of course, no national gallbladder cancer screening program is available. Ultrasound surveillance program needed in endemic beds. So for Tripura regional oncology practices, current landscape is tertiary cancer center RCC adopting multimodal treatment protocols. Gemcitabine cisplatin increasingly available for advanced cases. And AIMS Delhi, that is on gemcitabine cisplatin along with immunotherapy. Molecular profiling study, nowadays in all cases of gallbladder cancer we are doing core studies on big 3 mutation, KRAS, heart immune test, then FGFR mutation. Immunotherapy combination studies also going on like pembrolizumab, durvalumab, and registry development. Nowadays, National Cancer Grid initiative to standardize gallbladder cancer data collection from Northeast India, including Tripura. Diseases. So just see the data. Stage 4 gallbladder cancer. Why this is worse prognosis? Because of stage 4 diseases. Even with systemic treatment, 5-year survival is less than 10%. Without treatment in stage 4, survival is less than 6. and unresectable at diagnosis, that is 85%. So barrier for advanced stage disease in stage 4, the vascular engagement like portal vein, hepatic artery involvement, peritoneal carcinomatosis, like maximum patient comes with ascites, bowel implants, poor performance status for treatment, liver metastasis in 50% cases of stage 4 gallbladder cancer. So hepatic dysfunction limits the chemotherapy delivery. Nutritional depletion like cachexia, hypoalbuminemia impaired treatment tolerance. So the goals of care in advanced stages shift from cure to prolongation of survival, symptom palliation and quality of life optimization in stage 4 disease. So stage 4 disease is almost like palliation only, just to decrease the symptom of patient and to increase the quality of life. So this is the most important part for palliation in gallbladder cancer. Like tumor invasion in and compression of common bile duct patient will have biliopathy, obstructive biliopathy. So in obstructive biliopathy, if jaundice, like bilirubin is more than 3, we cannot go for any chemotherapy or we cannot go for any active oncology treatment. So first thing would be once ERCP guided stenting or PTBT for obstructive biliopathy. So ERCP stenting, maybe plastic stenting or metal stenting should be the first choice. If not possible or if it fails, you can do percutaneous transbiliary drainage. And if that also not possible, you can go for surgical bypass. Surgical bypass is usually not done because in advanced stage disease patient, general condition will be so poor, patient will not be fit for any surgery. So it's better to go for ERCP guided stenting. This is fluoroscopy guided biliary stenting, usually done for advanced gallbladder disease, gallbladder cancer, gold standard for palliation of malignant biliary obstruction. So multidisciplinary care in stage 4 gallbladder cancer is MDT, multidisciplinary tumor board decision with oncologist, gastroenterologist, palliative care, other radiation oncologist and surgeon. Medical oncology like what treatment, what palliative chemotherapy will be decided. Gastroenterology for ERCP stenting, nutritional support. Then there should be psychosocial support also for palliation. Like patient and family counseling should be needed. Financial support also, because if we counsel the patient, that patient in stage 4 and she or he will not survive for 4 to 6 months, patient never comes for treatment, whatever treatment required, they never come. So that support, counseling should be there. And at last, palliative care, that is for pain, nausea, vomiting, psychological support, spiritual care and advanced care planning. So at last I have added some slides on introduction to palliative care. Why we need palliative care for advanced distribution of adult in need of palliative care. This is mainly the total palliative care patients, mainly Alzheimer's disease. It is not only cancer, cirrhosis, kidney disease, chronic obstructive pulmonary disease, COPD, rheumatoid arthritis, Parkinson's disease. And the main part is cardiovascular and cancer. You can see here around 30 to 40% cases in palliation patients are under cancer registry. So this is old data. Even nowadays it is more than 40% involved by last stage cancer only. Patient needs palliative care. World Health Organization definition of palliative care in 2002 that says palliative care is an approach that improves the quality of life of patient and their relatives. Not only patient, their relatives too. So facing the problem associated with life-threatening illness through the prevention and relief of suffering by means of early identification and assessment, treatment of pain and other problems including physical, psychosocial and spiritual. It is not only the pain and treatment, the medicine part, should be associated with spiritual also, psychosocial also. So this is the total suffering of a cancer patient. It is not only the pain or dyspnea related to tumor, their total suffering includes social problem also, financial problem, social isolation and emotional problem. If patient diagnosed with cancer, they don't want any treatment because they think like I have been worshipping God for so long years, why I am having cancer. So there will be depression. Not only for patient, even patient family, also poor family, they are earning daily basis, so they cannot come for treatment. So in those cases, with the healthcare givers, even in district level also, in village level also, we have to consult them. So that even in nowadays in Tripura, we are giving 2000 rupees incentive for all cancer patients, whoever diagnosed with cancer, so that they can continue their treatment. So it should be counsel for all those patient and patient family also, and spiritual, of course, religious and otherwise spiritual problem is there. So symptom management is not only physician and nurses, but volunteers also can do for symptom management also. So in case of palliative care, now the idea of compassionate care. I think you have understood the movie name. That is Munna by MBBS, 2003. In that movie, what it has been shown, that is psychological support. Team is respect for everyone on your team, not only doctors, sisters, volunteers, whoever is there for cancer caregivers. Changes in paternalistic model of doctor-patient relationship in favor of Jadu ki Jhampi. So we have to understand the problem of the patient. It is not only the tumor. Everything comes under treatment on among the palliative care. Next movie is Anand, 1971. In that movie, Rajesh Khanna was advanced stage cancer patient. He does not want to spend his last days in the hospital. He just want to enjoy his last few days. Wants to be happy and make others happy in the face of death. So Anand made us think about quality of life. जिंदगी बड़ी होनी चाहिए, लंबी नहीं. काल होना हो 2003. हर पलिहा जी भर जियो जो है समा काल होना हो. So that famous writer Sanders famously said, we cannot add years to your life, but we will do all that we can do, add life to your years. Caregiver support. So Piku movie, you have I think you have seen Piku movie. The Deepika Padukone, she was always annoyed because of her father, because of aging, like constipated father, self-centered patient. But we have to control our emotion for support of cancer patient. That is geriatric care. And at last, end of life care. Though it is not accepted in India, some countries they accept, like Netherlands, Switzerland, Australia, Belgium. So in Gujarish movie 2010, Hrithik Roshan was quadriplegic and he wants euthanasia, that is mercy killing. So this machine, this is capsule, in spite of oxygen, it is filled with nitrogen. Okay, so that patient have pain-free death. But court rejects this plea in India. So at last, there should be good death. Family members should be there together, so that patient is to have good death, healthy life, peaceful life, pain-free death at end. So love at death. So the main line is for palliative care: to cure sometime, to heal often, and to comfort always. So at last, team health is also important. We have to take care of our own health to give proper care for cancer patient. So at last, the summary of my presentation, that is gallbladder cancer is aggressive malignancy and main hotspots in India, Tripura, South America. Female, okay, most common for gallstone. Diagnosis challenge is late presentation, diagnosis and surveillance of ultrasound by ultrasound CT scan. Surgical care, arterial dissection should be there for cure, and systemic therapy, GEMCs and durvalumab under trial. So let us fight against cancer. These are my some data source references. If any problem, you can contact me with my mail. My WhatsApp number has been given here. Thank you.